Inside a typical mid-sized medical practice, the front desk is a constant collision of immediate administrative fires. Phones ring, patients check in, and paperwork piles up, leaving no room for the complex work required before an appointment begins. This gap between scheduling and the exam is where pre-visit planning should happen, the process of verifying insurance, flagging care gaps, and reconciling medications. In most practices, this work is either done inconsistently or completely ignored. This erosion has a quantifiable price tag. Data across mid-sized practices shows that incomplete pre-visit planning drains 20 to 35% of total revenue through missed charges, open care gaps, and visits that could have been avoided with better preparation. For a mid-sized clinic, losing a third of its potential income threatens its continued operation. Stopping this leak requires examining the specific staffing failures that allow it to happen. A structural staffing crisis makes it impossible to maintain a consistent prep workflow. Medical assistants and front office staff currently see the highest turnover rates in the industry. According to the MGMA, 53% of practice leaders now identify finding qualified candidates as their single most difficult operational challenge. Replacing a medical assistant costs up to $12,000 in recruiting and onboarding. The practice also loses 4 to 6 weeks of productivity. Meanwhile, administrative support pay has climbed 39% over 10 years, making roles harder to fill. For the independent practice owner, the math no longer works. You cannot sustain consistent pre-visit planning when the people responsible for it are constantly leaving for higher-paying positions. Effective pre-visit planning is a complex, multi-step process. It requires checking insurance eligibility, flagging pending referrals, attaching lab results, and pre-populating the EHR template, often across half a dozen different software systems. This complexity is even more significant under value-based care contracts. These contracts rely on HEDIS measures to evaluate the quality of care provided, specifically checking if patients received recommended preventive services. The financial scale of these measures is enormous. For a health plan with 100,000 members, meeting a single quality measure can lead to $17 million in reimbursement. Despite those stakes, national adherence for high-priority measures often falls 10 to 15 points below targets. When the team isn't prepared before the patient arrives, the window to close those care gaps disappears. Pre-visit planning is the only reliable way to secure HEDIS performance. It transforms clinical prep from a background administrative task into a requirement for the practice's financial health. Modern practices are solving this by isolating pre-visit planning from the chaotic front desk. They use an insulated workflow where specialized virtual medical assistants handle the entire preparation process remotely. These specialists undergo 40 hours of practice-specific training. They learn your specific EHR platform, your clinical protocols, and your payer mix even before they begin managing any patient charts. Because they work directly inside your existing EHR during regular business hours, they function as a seamless extension of your local clinical team. This human expertise is layered with an AI quality gate. Natural language processing extracts data from patient records, while a duplicate detection system flags redundant entries, ensuring the doctor receives a clean, accurate chart. This model establishes a standardized operational system. It ensures that every chart is prepared according to the same high-quality criteria, regardless of staffing changes at the physical office. The economic shift is significant. A U.S.-based administrative employee costs $60,800 per year when you stack salary, benefits, and taxes. A dedicated virtual medical assistant costs just $21,600. That creates an annual savings of $39,200, a 64% reduction. This model also includes built-in security and compliance. Every workflow is backed by HIPAA, SOC 2 Type 2, and HITR US Trust certifications, ensuring patient data is handled with the highest level of protection. By outsourcing this function, a practice owner converts a volatile, expensive staffing liability into a predictable and profitable asset. Implementation is fast. Practices can go live in as little as 48 hours and typically see a measurable return on their investment within the first 90 days. Staffingly has delivered this model to more than 800 healthcare providers across the country, generating over $14 million in total savings for their clients. Stop the revenue leak caused by staffing turnover. Visit staffingly.com/demo or call 1-800-489-5877 to start a risk-free pilot program. Success in modern medicine requires evolving how the work gets done. It means ensuring every patient visit is fully prepared before they arrive.